Hello, class, and welcome to chapter 14. Today, we're going to be talking about blood. So when we think about blood, keep in mind that this is a connective tissue, and this connective tissue has a liquid matrix. So if you remember, there are cells, and then there's this extracellular matrix that goes around it. So when we think about the idea of blood, blood is going to transport vital substances. It's going to help with distribution of heat, and it actually helps to maintain stability of interstitial fluid. The amount of blood varies within your size, and actually can also be by the gender as well. But blood's about 8% body weight, and usually it's about 4 to 5 liters in females and about 5 to 6 liters in males. And when we think about blood, remember that there are blood cells, and then there's this liquid portion surrounding those cells. Now, we don't necessarily call them cells because they're not truly cells. Like red blood cells and platelets are really technically not cells. So instead, what we do is we call them formed elements. But these formed elements are known as red blood cells or erythrocytes, white blood cells or leukocytes, and then platelets or what is known as a thrombocyte. And so when we think about blood, again, you'll see that it either can have a very dark, almost maroon scarlet color, or it can be a bright red, depending on if you're finding it from an artery or from a vein. But when we look at blood itself, again, remember, this is a connective tissue. And these cells are known as your formed elements. That's your cellular portion, and everything around it or surrounding it is known as plasma, this liquid portion. So when you go to see kind of the breakdown, it's about 55% plasma, about a little less than 1% for this buffy coat, which is your white blood cells and your platelets, and then the rest is going to be red blood cells. So again, when we see this piece, this should actually make total sense because your red blood cells are going to be your oxygen carrying capacity. So you need a lot of them in order to be able to distribute and actually have that movement of oxygen. And again, we have a great deal of the plasma because the plasma is going to be typically made up of about 90% water, but you also have electrolytes, you have proteins, you have clotting factors that are going to be found within this plasma portion. And so when we look at the total percentage, it should be 100%. So when we start looking at these percentages, we may look at something called the hematocrit level or the packed cell volume. And what we're doing is we're looking at the number of red blood cells over the total volume to make sure that we have a proper hematocrit level or PCV level, I apologize. All right, so again, when we start to look at this breakdown, 45% of blood is going to be these formed elements. And again, primarily red blood cells, which we know as erythrocytes. A little bit will be platelets, those little fragments known as thrombocytes that help with clotting. And then again, we have a very small amount of white blood cells. However, as little as the white blood cells that we need, we actually have quite many different types of white blood cells that you can see. And so we're going to discuss those later on here in just a moment. But on the plasma side, you're going to see that, again, mostly it's going to be composed of water, 90 to 92%. We will see electrolytes such as sodium, potassium, chlorine, magnesium. We'll also see some nutrients and vitamins, hormones. We see proteins like our globulins for immunity. We see albumin, which helps to maintain our colloidal osmotic pressure. And we see fibrinogen, which actually helps with clotting as well. And then again, we have our gases. Now, when we discuss the idea of red blood cell formation, we use the term hematopoiesis. We've actually mentioned this before when we were talking about bone, because we mentioned the idea of the red bone marrow and how that helps with the formation of red blood cells and blood cells in general. So what happens with hematopoietic or hematopoiesis is the formation of blood cells. So when we talk about hematopoietic stem cells, we're going to be discussing the idea of basically your immature baby cell. And so when we discuss the hematopoietic stem cell, it can actually start to differentiate to either these myeloid stem cells or lymphoid stem cells. Now, I'm not going to ask you to know this chart, but I just kind of want you to be able to see kind of where these differentiations happen and where the specializations happen. So here at the bottom, again, through this series of events, we end up with our erythrocyte. As you can see from this megakaryoblast, we have a megakaryocyte, which is a very large cell, and that ends up becoming fragments that we see as our platelets. And then from there, again, we get these white blood cells that we're going to separate into granulocytes and agranulocytes. And we'll be discussing that here in just a little bit more detail. But just figured I'd show you. And again, if you remember that hematopoiesis is going to originate in the red bone marrow. And again, from there, you have these stem cells that are going to mature, differentiate, and they will start to reside in different areas. Gives you a little more pieces of what to see. All right, so again, when we think about this rise that can happen, again, they are either going to separate into these lymphoid stem cells or myeloid stem cells. The lymphoid stem cells give rise to what are called lymphocytes, and we're going to discuss that. Those are your T and B cells. And the myeloid stem cells give rise to your erythrocytes, again, the fragments, which are known as platelets or thrombocytes, and again, are different types of white blood cells. Now, when you actually look at a red blood cell, again, we call it an erythrocyte. Erythro means red and cyte means cell, so we just omit the blood. It has a biconcave shape to it, so it sort of looks like a Werther's candy, and it does not have a nucleus or a mitochondria. So it cannot just divide on its own. It can't go through the cell cycle, which is why it has to be produced in the red bone marrow. And when we think about this, although it doesn't have this typical cellular structure to it, it actually makes sense from a structural perspective because this helps to give rise to oxygen, because it's going to have this protein aspect to it called hemoglobin. So it's actually 1/3 of this hemoglobin. And hemoglobin helps to bind onto oxygen. So when we think about hemoglobin, there's a heme portion, an iron portion, and there's this globulin portion. And it allows for oxygen to be able to bind onto that one hemoglobin group. And there are hundreds of thousands of hemoglobin within a red blood cell. So again, it allows for great oxygen carrying capacity. If it is carrying oxygen, we call it oxyhemoglobin. If it is not, we call it deoxyhemoglobin. And usually, again, we'll see changes in color. If it is carrying oxygen, it's going to be a bright red color versus if it is not, it's going to be more of a darkish hue when we look at blood. And when we think about red blood cell counts, again, this should be about 95% of your formed elements. Again, not going to ask you to know the ranges, but this just sort of shows you these different typical ranges that we can see. And knowing these ranges is very useful for diagnostic tools to either, again, be able to see if there maybe is a blood disorder, if maybe there is a problem with diet, or again, it can help with evaluation of progress too. And changes in red blood cell count, again, with structure, change function as well. So this is going to cause issues with oxygen carrying capacity. So while you'll see problems from a blood issue, you may see problems at a cardiovascular and respiratory system as well. And when there is issues with oxygen levels, we can format something called erythropoiesis. So be very careful, make a note to yourself. Hematopoiesis is the formation of blood cells in general, white blood cells, red blood cells, platelets. Erythropoiesis is the formation of red blood cells. So be very careful. It's something very different. So I would make a little quick note to yourself about that. Now, what happens here is that it occurs in the red bone marrow, but this is due to low oxygen levels in the blood. So when we think about this, what you're going to notice is that low concentration triggers the liver and the kidney to release or stimulate what is called EPO or erythropoietin. So this allows for a release. So again, your oxygen levels are low, the liver has receptors that sense this, there's kidney receptors that will sense this, and they help to stimulate and release that erythropoietin, or what's known as EPO. And the EPO is going to then be distributed in the bloodstream, and it triggers the red bone marrow to start producing more erythrocytes, more red blood cells. And this will usually take a few days to kind of kick in. And so it takes a little bit of a while, so it's not something you'll immediately see, but again, it does help with that generation and helping with increased oxygen carrying capacity. And this is a very big thing to keep in mind too, especially if someone is developing anemia where they have issues with their blood levels. Now, another thing to make mention of as well, when we talk about red blood cells, is that they only last for about 120 days. That number is very useful. And this is what diabetics will use to monitor their A1C levels. So instead of having to poke themselves to get their blood sugar level concentration, which can fluctuate, the A1C level stays relatively pretty consistent through that 120 days to be checking it. So every 3 months, again, you'll get this discarding of red blood cells and you'll have new blood cells coming to the area. All right, now when we think about red blood cell production, you have to have vitamin B12 and folic acid. It's actually required and necessary, as well as iron is necessary too for red blood cell production. So in this circumstance, when we think about red cell production, we have to have iron in order to make this happen. So because of this, there are some diseases that can occur, and you can hear about the term anemia. Emia means in the blood, and an means without. So this is a condition where you have very low oxygen carrying capacity due to either problems with hemoglobin or problems with actual red blood cell formation in general. So you may hear about aplastic anemia, which is very common for those that are undergoing radiation or maybe have had exposure to toxic chemicals, and it actually damages their bone marrow. You can hear about iron deficiency anemia. That's very common. And usually this is a lack of iron. So you have issues with hemoglobin. Pernicious anemia is an inability to absorb vitamin B12. And because of that, you have these very large, huge cells that are going to not be useful. And they get discarded very quickly. Sickle cell anemia is a defective gene disorder in which the red blood cell has an abnormal sickle shape to it. And again, therefore, they get discarded too early over that 120 days. And you may also hear about thalassemia, which is another defective gene disorder, but it causes deficient hemoglobin. And again, the red blood cells are also very short-lived. All right, so then we have our white blood cells, which are known as our leukocytes. They help to protect against disease. And so these are what you consider like your immune system cells. And they are going to be under control of what are called interleukins and colony stimulating factors. So again, there's a very small amount. You don't just normally have them distributed through the blood in high volumes, but if there is an infection, inflammation, or a chance for some sort of reaction, you will see an increase in white blood cell count. Now there's two major categories. There's 5 different types. Granulocytes and agranulocytes are the 2 categories. If you hear granulocytes, think about little granules. They have like a granular cytoplasm. So you'll see that they look like they have little nitty gritty pieces to them. And they have a pretty short lifespan. They live a couple days. They can be anywhere between 2 to like 10 days. You'll hear about neutrophils. They are usually the first ones on the scene for inflammation as well as for like a bacterial infection. Eosinophils are going to be used for parasitic infections and also during like allergic reactions. And basophils play a very big role in inflammation, allergic reactions. So again, when someone is undergoing anaphylactic shock, you'll see a very high rise in basophils. When you look at neutrophils, they have very funny, they have a very funny nucleus. It actually looks like little segments. So sometimes they're referred to as segs. Eosinophils are going to stain like a reddish color, and basophils are going to be like a blackish blue color with those granulocytes inside. Agranulocytes don't have granules, and you will see lymphocytes, which are T and B cells that are very helpful in your immune system response. And then monocytes are a very large cell that actually convert into macrophages, and they help with phagocytosis. So again, when we look at neutrophils, you can see that they're this light purple color. They have those little granules inside. And again, they have these funky lobes inside of them too. So that's kind of what helps you to identify them. So from a lab setting, that's sort of what we would look for. They're the first ones to arrive on site whenever there's an infection or maybe an inflammation stage. They are going to perform phagocytosis as well. So they help with cell eating and getting rid of whatever bacteria or whatever funny sortiness is going on. And they are very highly elevated in bacterial infections. So if someone has an infection or someone has a high white blood cell count, they would look at neutrophils and maybe say, okay, I think they have some signs of a bacterial infection. Eosinophils, again, have like a reddish stain to them. And again, you can see those granules. They are usually going to be due to allergic reactions that you'll see an increase in them, or again, from a parasitic worm infection as well. For basophils, again, they have this like bluish black color that you'll see. They help to release histamine and heparin, so they help with stimulation of inflammation, as well as helping with blood clotting. And again, you'll also see them be very high during allergic responses as well. And then when we see monocytes, these are our agranulocytes. They have like a kidney-shaped nucleus. They're very large, and again, they will end up becoming macrophages once they leave the bloodstream. And they can live for weeks or months. They can actually, they're not quite as short-lived, but their goal is to help to phagocytize the area. So they clean up bacteria, dead cells, debris, anything that's just not supposed to be there. And then finally, again, these guys can actually live for many years. These are our lymphocytes. So you'll hear of T lymphocytes and B lymphocytes, or your T and B cells. And again, they are major when it comes to immunity. So when you think about creating plasma cells, thinking about creating antibodies, these are the guys that we start to talk about. B cells are the production of antibodies. T cells actually directly attack and kill the pathogen. So quite useful in our bodies, and we'll discuss them more coming up in the immune system response. All right, so again, for white blood cell count, this is just showing you those little changes that can happen. Leukocytosis is an elevated white blood cell count. Usually, again, you see this due to infection. You can see this also with loss of body fluids. And even with vigorous exercise, it might kind of go up a little bit too. Versus leukopenia is an abnormally low white blood cell count. And usually this is due to like AIDS or anemia. And so what they will do, again, is they will notice whether they're high or low, and they'll do what's called a differential white blood cell count. So again, they're trying to see, okay, is this person having an increase in white blood cell count because there's a bacterial infection? Is it viral? Is it a parasitic infection? And it allows them to be able to diagnose and treat. All right, so again, just to sort of help you with these pieces of what you could potentially see, what does this mean when you have these elevated numbers? All right, and then finally, again, we have those little fragments for those megakaryocytes. They are known as platelets or thrombocytes. And their goal is to help with hemostasis, which is going to be formation of blood clotting and helping to stop bleeding. And what happens is they release serotonin, which causes smooth muscles to actually contract. And we'll discuss a little bit more about hemostasis coming up here in just momentarily. All right. Before we get too far into the physiology portion, we do have to clear up the idea with plasma really quickly. So we've talked about these ideas of formed elements. Now we need to discuss the idea of plasma. Plasma is a straw colored liquid portion. And again, most of it is going to be water. We will see that there are gases and hormones, vitamins as well. And then there also will be ions and fluids to help maintain valence as well as pH. All right, so here is a good little table to sort of be able to see from that protein aspect. As you can see, majority of them are called albumin, and they help to maintain what we know as COP, colloidal osmotic pressure. And they help with the idea of salt and water kind of moving back and forth within the cell. Globulins are going to help with actually like the gamma globulins help with lymphatic aspect, versus alpha and beta are going to be useful for liver, for transporting of fats and soluble vitamins. And then finally, fibrinogen is going to play a role in what we call coagulation, which is helping with that blood clotting formation. And here are some gases and nutrients to be able to see as well. Again, most important gases, oxygen and carbon dioxide. All right, and again, we can see a lot about those different types of electrolytes that are found. And again, they are going to be very useful to sort of be able to move and be able to be distributed throughout the blood. All right, now getting into this idea of the stopping of the bleeding. So just as a FYI, and again, trying to help out to make this make more sense. If you see hemo or hemato, this is referring to blood. So hemostasis is the stopping of bleeding. So basically, again, you cut yourself, and now what do we do to stop that bleeding? And there are 3 different factors that are going to be taken into account, 3 different actions that you do have to know. So make sure you like circle this or put something around it to make sure you know these different mechanisms. But the first mechanism that we're going to talk about is the vascular spasm. So this is, again, when you actually do the cutting or the breaking of a blood vessel. And what's going to happen is the smooth muscle contracts very rapidly because the idea is that you want to make the vessel smaller. So let me try to attempt to draw a picture here. Yeah, let's not make it. Let's make it black. So again, here's your normal intact blood vessel. Something happened to now where it has this little cut in it. And now blood is going to be able to leave. So in order to kind of reduce that a little bit, we have constriction, where these are going to be coming closer together to sort of try to tighten that spot up. And again, trying to make it to where that blood loss is going to be a little bit slow, or at least kind of try to slow it down if it can. And the ends of the vessel may actually close completely. So this is actually triggered by the vessel wall, by pain receptor reflexes. And again, it can last a couple of minutes, but it can continue effects for up to 30 minutes. And this just allows time to actually have the other steps sort of come in and allowing for blood coagulation to take place. It kind of holds it off, if you will. So imagine that you were in a boat that had a bunch of little holes, and to prevent it from sinking, you kind of put Band-Aids over top of them. You know, it's not a great long-term perspective, but again, it helps in short term to sort of get you to the next step. The next step is actually creating a platelet plug. And so basically what you're doing is plugging up the hole. And it's triggered by exposure of collagen. And it's actually the exposure of platelets to collagen, where they adhere and they have formed this plug. So as you can see, again, there's this nice little tear that's now happened, this break in the vessel wall. And again, you're going to have this constriction happening where it's kind of coming closer together to sort of keep and prevent as much blood loss as possible. But what you can see is these platelets are actually migrating to this area. And as they're migrating, they're actually adhering to each other. So the platelets are kind of sticking on top of each other, one right after another. And they're going to then produce this plug. So again, kind of plugging up that hole to make sure that, again, long-term wise, this is gonna hold. And then finally, the final step to actually create a fibrin clot really kind of seals the deal. And this is when we get into blood coagulation. So it's the most effective, and it occurs within about 15 minutes. And you're forming a blood clot through a cascade of events. It can be initiated by two different methods, this extrinsic or intrinsic mechanism, and it's using clotting factors to make this happen. I'm not going to ask you to know nitty-gritty details about this. I just kind of want to tell you the overall basics. I do want you to know that there is an intrinsic and extrinsic clotting system. And I do want you to know that they actually need vitamin K for this function of clotting factors. And for those of you that have had children, you'll know that before you leave the hospital, they actually give kids the vitamin K injection. And this is, again, to help with that promotion of clotting factors, especially for a male, and especially for a male infant that has undergone a circumcision. It's very much needed for clotting factors. And the coagulation depends on sort of this balance between what are called procoagulants and anticoagulants. Procoagulants are going to promote that clotting. Anticoagulants are going to inhibit clotting. So there's kind of this balance back and forth. But the major event that happens is where we actually are making these fibrin threads. So fibrinogen, that protein that we've seen in that plasma, is going to actually convert into fibrin. And fibrin is what you're seeing down here. So let me draw it in blue. So when you look at all this yellow component where it sort of looks like hay kind of stuck over top of these red blood cells, that is fibrin. And it's trapping the red blood cells to make sure that they can't release through that capillary or through that blood vessel. And so I do want you to know these different mechanisms, so be able to match them. And again, there are these different mechanisms for coagulation. It can be intrinsic or extrinsic. Extrinsic is going to be where there's some sort of damage to the outside of the blood vessels. And it can also be due to a release of a factor 3. But basically what you're going to see take place is this series of events. And what will eventually happen is there's this protein called thrombin, and it converts to fibrinogen, which then eventually is going to convert into fibrin. And the fibrin threads actually stick to the damaged blood vessel surface, and they trap the cells as well as platelets, and they form these massive blood clots. So again, this is an example of positive feedback. Once clotting begins, it's going to allow for more bleeding and more clotting to take place. Versus intrinsic is going to start even without the tissue being damaged. Usually it's activated when the blood comes into contact with a foreign surface, and it's usually triggered by this Hagman factor. And what you're going to see is, again, through this series of events, the results are the same. They're going to end up with that fibrin mesh, and they'll end up with a fibrin blood clot. So what you'll see here take place is, again, you'll see intrinsic here, and we see extrinsic over here. And what you'll notice is actually this activation requires a very important ion, calcium. So again, be careful with some of these questions that may pop up. For red blood cell production, you have to have iron. For coagulation and blood clotting, you have to have calcium. But what you'll notice, you have this extrinsic factor, you have this intrinsic factor, and what happens is they converge at this same spot, this factor 10. And then again, this allows for that prothrombin to go from prothrombin to thrombin, which allows fibrinogen to convert to fibrin, which helps with actually making that fibrin clot. So I'm going to ask you a little bit, I'm not going to ask you the crazy detail behind it, but I do want you to know that prothrombin converts to thrombin, and then thrombin converts fibrin to fibrinogen, or fibrinogen to fibrin, which then overall makes the fibrin clot. So I kind of want you to know this last little component to it. That's what I'll ask you. Versus intrinsic and intrinsic, I won't ask you the detail for that at this point in time. All right, so this just kind of helps you to see those different clotting factors. You do not have to memorize this. This is for your FYI. All right, and when we think about blood clots themselves, after a blood clot forms, it actually retracts and pulls the vessels together, and it's kind of squeezing the serum from the clot. So when we think about the term serum, it's actually plasma minus the fibrinogen. And plasmin is actually going to help to digest the fibrin threads, and it helps to dissolve the blood clot. However, you can see some abnormal clotting that can take place. A thrombus is an abnormal clot that forms in a blood vessel, versus an embolus is a blood clot that actually is broken off and it moves through the blood vessels. And either one, again, can be extremely dangerous. While we think of blood clotting as being a very good thing, again, developing a blood clot in an area that shouldn't can cause some major problems to take place. And so when we think about these abnormal pieces, again, you may hear of thrombosis, which is going to be a blood clot in a very vital organ. You can hear of an infarct, which happens usually in the heart. So when you think of like a myocardial infarction, that's a heart attack. So the tissues are actually dying because of this blocked vessel. You can have an embolism, again, which is a clot that travels and then blocks a very tiny little vessel, usually in the lungs or the brain. So you may hear of like a pulmonary embolism. And atherosclerosis is actually an accumulation of fat from usually an abnormal clot formation. And usually that common form is the thrombosis. And that's what you can see down here at the bottom is this yellowish fatty plaque that has been basically accumulating in this poor guy's arteries, unfortunately. And again, now you can see that the space to where blood flow should be happening is very, very small in comparison to this guy here. We call this middle ground the lumen. And again, you can see that there's a very large, very nicely dilated open spot for the lumen for the blood to kind of flow through, versus over here, that's deeply diminished. All right, and again, we can prevent coagulation from taking place. So again, we like blood coagulation to happen when you actually have bleeding taking place. But as the clot forms, again, fibrin's going to absorb thrombin, and it prevents the clotting action from basically spreading. Antithrombin helps to inactivate additional thrombin, and we also can secrete heparin as well, which is an anticoagulant, which is why, again, if someone has issues with blood clotting, maybe that they have an overproduction of clotting, or they may have clots, you may hear about them being on heparin or Coumadin. All right, and these are just some of those factors that help again to inhibit blood clot formation. All right, last little bit that we're going to discuss for blood is the idea of blood groups. So they are known as the ABO blood groups, and they are explained and observed in many different types of incompatibilities. So there's actually a lot of history behind blood transfusions and blood typing. It's kind of interesting, especially like thinking back in time when the first blood transfusions happened. People were using goat's blood and dog's blood, and it was not working out very well. And then what also would happen too is, depending on like royalty and stature, people were using their servants as transfusers. Basically, they were taking the blood from their servants and using it to transfuse for them when they needed it. And sometimes it worked and sometimes it didn't. And many thought it was because of a religious or a stature issue, or maybe that person wasn't a good person and this is why it wasn't working out. And it took many years to actually truly explain the ABO blood typing and why this works. And what actually happens is there's a particular antigen gene for blood type. So blood types are actually distinguished by the proteins on the red blood cell. So for instance, when we think about a red blood cell or a person's red blood cells, if you are like me, and I'm not going to mention positive or negative at this moment in time, I'll discuss that here in just a moment. But if you're like me, you have nothing on your red blood cell. So my blood type is an O. For someone else that may have the A antigen, this would give them A blood. For someone that has the B antigen, this would give them the blood type B. And some people have both. They have A and they have B, which would give them AB blood. So blood types are actually distinguished by the proteins that are on their red blood cell. And that's what you can see here. These are the different types of blood types you could potentially be. We will discuss positive and negative here in just a moment. But again, for right now, just think about these ABO blood groups that you could potentially see. And it has to do with what's on the red blood cell. All right, now you may hear about an antigen. An antigen is a molecule that evokes an immune response. And for us, we have these antigens on our red blood cells. So what happens is we produce antibodies against particular antigens. So for instance, an antibody is actually going to protect us from a specific antigen. So for us, again, for someone like me that's O blood, I don't have anything on my red blood cell, but I do have in my plasma an anti-A. And in my plasma, I also have an antibody called anti-B, which is what makes me incompatible to be able to receive A blood, AB blood, or B blood. I can only be given O because of these antibodies. Now, someone that has AB blood has their red blood cell, and again, they have the A antigen on it. They have the B antigen, but they have no antibodies. So because of that, they are what is considered to be the universal recipient, meaning they can get blood from AB, A, B, and O. And we'll discuss that here in just a moment. But that's somewhat how it works. Now, for someone that has A blood, again, they have the A antigen on their red blood cell, and they're going to have the anti-B antibody in their plasma. Versus someone that has B blood, again, they have the B antigen, and they have the anti-A antibody. So because of this, for someone that has A blood, they can be given A blood, and they can be given O. Same thing over here. They can be given B blood, or they can be given O. So there's a lot of mechanics that go behind this, but this is sort of in a nutshell, idea of what takes place. Now with the antigen, again, it's a molecule that actually evokes the immune response. The antibody is the protein that basically reacts against that antigen. And when they come together, they actually clump. This clumping is called agglutination that takes place. And this is what can evoke the serious transfusion hell, if you will, because it just evokes a cascade reaction to where now that person has had transfused blood and it is all clumping. So normally what they would have to do to keep that person from potentially dying is drain that person's blood and give them another transfusion, which obviously is not an ideal situation, but it does happen. All right, so when it comes to ABO blood grouping, again, it's on either a presence of antigen A or antigen B, whether they have that on their red blood cell. And again, whatever they have is on the antigen, and that's what's on the red blood cell. Whatever they don't have is the antibody that will be found in their plasma. So again, for myself, I am O blood. I'm actually O positive blood. So I don't have either antigen. And because of that, I have the antibodies A and B. So if you wanted to kill me, you could give me anti-A blood, or you could give me A blood, AB blood, or B blood, and you'd be succeeding in that. So I can only be given O. But I am the universal donor. I can donate to everyone else because there's nothing on my red blood cell. For someone that is A, they have the A antigen, and therefore they have the antibody anti-B. So they can be given A blood or they can be given O blood, but they cannot be given AB or B. So I hope that kind of makes a little bit more sense. All right, when we start thinking about blood types and frequencies, again, you can kind of see that there is a change. And again, a lot of this can be due to region of sort of what blood types you are able to see. So just something a little bit interesting. Blood types that AB that always just make me very interested is that, again, you tend to see it more in a more Asian ethnicity versus for type O, again, you see more along the lines of a Caucasian kind of area, and also in Hispanic too. So again, a lot of it has to do with traveling and moving, and again, sort of that genetic predisposition. And again, if you guys are ever interested in this, I have a wonderful book called The 7 Daughters of Eve. I think I mentioned it before with mitochondrial DNA. They also discuss blood typing as well. And again, this is just kind of showing you a better picture of whatever's on the red blood cell, again, is going to be the antigen that they have. Therefore, that's their type. And the antibody is what they do not have, what they're going to protect against. And when they put the two of them together, they clump, they agglutinate, and that's what you can see in figure D. All right, so to make sure that we understand the idea between recipients and donors, the recipient is the one that is receiving the blood, the donor is the one giving the blood. So myself, I am type O, I am a universal donor. Because I don't have anything on my red blood cells, when I donate my red blood cells to someone, that is going to be very useful, and I can donate to anyone. Versus type AB is the universal recipient. They can get blood from anyone because they lack those antibodies. So they can receive blood from anyone versus I can donate to everyone. I can only receive O, and AB can only donate to AB. But again, this is what makes us the universal donor and the universal recipient. And then finally, now I can add in the positive versus negative. So I myself as Rh positive, I do have this additional antigen. So again, I don't have A or B antigen, but I do have what is known as the D antigen. And I forget why it's called the D. It used to be Rh is known because of the rhesus monkey, but I forget why they call it the D antigen. But anyway, the Rh antigen is the antigen D. So for me, this is what my blood type looks like. I am O positive. And if you are O negative, you just don't have that D antigen. When it comes to antibodies, again, anti-Rh antibodies only come with the response of having it be present. And this isn't something that you're actually born with. So someone that has Rh negative, so let's just say hypothetically you're A negative and you've never been exposed to any other type of blood, you don't actually have antibodies. And so this is actually what leads to a really, really rough disease and condition, especially for mothers, which is called hemolytic disease of the newborn. And this is where mom's blood, especially if she's negative, can lead to a series of events. This is why they actually test you while you're pregnant to see if you have positive or negative blood. And so basically what happens is mom is negative. Let's just say hypothetically, she is a negative. What happens here with this baby is the baby is going to have, let's just say, A positive blood. So baby's born and a little bit of blood entered mom's bloodstream during childbirth. So this baby's fine, no big deal. But what happens now is now mom, because she had exposure to that D antigen, now mom makes antibodies for it. So second baby rolls around. This baby is also positive. And again, mom is A negative. This causes major problems in the next pregnancy because of the fact that mom was able to have antibodies. Those antibodies actually attack the fetus and they attack the blood cells. So it's called hemolytic disease of the newborn. And it is not a disease that any mother would want to undergo. Now, the funny thing is though, if mom had another baby and it was negative, there would be no problem. So this is kind of how it came out. You know, again, mom was fine on first baby. Mom has a baby that has negative blood second time around, no big deal. Third time around, mom has positive baby and ends up with hemolytic disease of the newborn. So to prevent this from even happening now, if they know that a mother has negative blood, they automatically give her something called RhoGAM. So it prevents her from actually making antibodies. So basically to keep any of this from taking place, they basically prevent mom from creating antibodies, and therefore it's not a problem on first pregnancy, second pregnancy, fifth pregnancy. She'll be fine and baby will be fine as well. All right, now here are some other blood disorders just to be able to see. I like to make mention of hemophilia, which is going to be several different types. And this is usually due to a clotting factor problem that allows the person to just keep bleeding. They don't actually clot correctly. Most common is factor VIII hemophilia. That's the most common. You may hear of sickle cell disease. Again, I kind of mention it quite frequently. This is where instead of that biconcave shape, they have more of a sickle cell approach. And unfortunately with sickle cell disease, this is pretty rough. A person's not going to live as long, and quality of life is also impaired because they tend to have bone pain because they're constantly making red blood cells. So it causes crowding. They are trying to actually remove their red blood cells, which the spleen is the one that actually helps with that, to destroy red blood cells. So a lot of times their spleen will kind of be clogged and will actually increase in size. So they'll have something called splenomegaly. They tend to have issues with anemia, they have pain, they have other symptoms. And again, the big thing too is that they have issues with oxygen carrying capacity. So they have a lot of respiratory distress. So not a very fun disease. And then von Willebrand's is also quite common actually too. This is a lack of a clotting factor, which is called von Willebrand's factor. And it's less severe than hemophilia. And most of the time you won't actually know you have von Willebrand's until you undergo surgery. So this is one of the reasons that if you've ever had it, they ask you how you do with anesthesia, and then they ask you how you do with blood clotting. Do you bleed a lot? And it's really more of an issue for someone that's undergoing massive surgery that they have to be careful. So von Willebrand's disease is actually, again, not as common, not as severe as hemophilia, but it is quite common. All right, thank you all for listening, and I hope you have a wonderful day.